Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Brian Harris. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, Doctor. Good morning.
Good morning. What's your problem?
Well, last year I had a traumatic injury to my left posterior. I got hit from a boat while I was in the water. I immediately rushed to the hospital where I had to undergo surgery. I'm still having an external fixation on the wound for healing fractures in the leg. I had undergone grafting and full-thickness skin grafting, close to defects in my posterior thigh. It is almost healed right in the gluteal fold on the left area. In several areas along the graft site and low in the leg, there is several hypergranulation tissue developed.
Is there any bleeding from the wound?
No, Doctor.
Okay, what's your age?
42, Doctor.
Do you drink or smoke?
No, Doctor.
Had any other illnesses in the past?
Nothing other than Clostridium difficile in the recent past.
Are you taking any medication?
I'm taking Cipro and Flagyl.
Are you allergic to any medicine?
No, Doctor.
Any illness history of family members?
My maternal grandmother had pancreatic cancer. My father had prostate cancer, and he has heart disease and diabetes.
Well, your physical examination results are perfectly okay. Cardiology reports are regular. There is no S3, S4 or gallop. There is no murmur. Abdomen is soft. It is non-tender. There is no mass or organomegaly. Your right lower extremity is unremarkable. Peripheral pulse is good. Your left lower extremity is significant for the split-thickness skin graft closure of a large defect in the posterior thigh, which is nearly healed. Hypergranulation tissue both on your gluteal folds on the left side. There is one small area right essentially within the graft site, and there is one small area down lower on the calf area. There is an external fixation that comes out laterally on your left thigh. The pin sites look clean. There are several multiple areas of hypergranulation tissue on the left posterior leg associated with a sense of trauma to your right posterior leg. I would recommend a series of treatment with chemical cauterization of these areas till these are closed.
Extract 2, questions 13 to 24. You hear a nurse talking to a patient, Shauna Burke. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, I've been told that you're particularly worried about your general health of late, mainly because of your job. Is that correct?
Yes, it is, Doctor. I'm 28, and as a model, that's practically near retirement. It's so important for me to look my best for shoots and commercials, but I've been noticing weird things happening on my face that I thought I'd get checked out.
When you say weird things, what do you mean?
Like this, these dark shadows on my eyes, especially on the lid. It's really wearing me out. I've been feeling this way, this extreme tiredness, for as long as I can remember now, and it's not just my mood. I've lost a lot of weight recently too. I know what you're thinking, it's every model's dream.
No, I wasn't thinking that.
A lot of women would give me a slap if they knew I was having a moan over losing 20 kilos in a month without even trying. But you know what? I'd give my right arm to go back to my normal look. Fresh-faced, bright eyes. Right now, I look a right state.
I don't think that at all, Miss Burke, but I would like to investigate this for you. It's possible that you've come down with something, and I'd like to give you some treatment and get you back to your normal self, okay?
Thank you.
Would you tell me when you started noticing these symptoms?
I really don't know. I've been working a lot lately. Been booking a lot of domestic work in London and sometimes overseas too. When I got back from France last month, on or around the 11th, I think, I just found my day-to-day just that much harder. For example, I usually love the hustle and bustle of my job, the last-minute calls, the late nights, and the constant after-parties. I just jump in the Merc and away I go. But recently I've been finding it super tough to drive. I thought maybe it's because I'm on the other side now, but it's more than that. When I'm behind the wheel, I feel a little spaced out, like disoriented, not knowing where I'm going or how I'm going to get there. You're looking at me like I've grown another head. I must sound so silly.
Not at all. I'm just thinking about what you've told me, how best I can help. Do you know if anyone in your family has been through anything like this?
Not that I know of.
Okay, you mentioned that your job can be very social. Do you smoke or drink?
I don't smoke, and I only drink when I'm out with people I know and trust. There are way too many scary stories of handsy photographers for me to get plastered with people I don't know.
Sounds like you've got a really good head on your shoulders there. Now, Miss Burke, I have to ask, because there's no indication on your personal medical history either way, but because you mentioned drastic recent weight loss, would you tell me about your diet?
Sure. I eat pretty well, if that's what you're wondering. I'm vegan, and so my diet is pretty healthy. I will occasionally eat out at a Frankie and Benny's, for example, but you wouldn't catch me dead at a McDonald's. I've managed to stay off junk food since I was very little. I used to be bulimic when I was 14, but after the counseling, everything is okay, and I've had what I think is a really healthy attitude to food.
I'm glad to hear that.
So, any idea what's wrong with me, Doc?
We'll need to run some tests to confirm things, Miss Burke. I don't want to say anything that I'm not sure of. We'll run a blood test today, and I'll call you in for others within the week, after we've received the results. In the meantime, I'm worried that you're not getting enough sleep. Do you think you could set up and stick to a routine?
Like a sleep schedule? Yes, I've done that before, and it actually worked.
I'm glad to hear that. At least that would help you get some well-earned rest while we're trying to get to the bottom of all of this.
That is the end of Part A.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best, according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a nurse briefing a colleague about a patient. Now read the question.
Okay, this is Linda. She's a 60-year-old female who was admitted through emergency with chest pains today. She's abnormal ECG with a negative troponin so far, and she's reporting a 5 for her pain. That's down from 8 on admission. She's on a cardiac diet, so she's nil by mouth from midnight, and she's okay with that. Tomorrow morning she's down for a stress test. She has a right forearm 20 gauge with normal saline at 75. Linda's alert and oriented, and she can ambulate with assistance. She did report some dizziness in the ER, so we have a falls risk wristband in place. She's aware that if she needs to go to the bathroom, she needs to press the call button, but she's a bit resistant to the idea, so you need to keep an eye on her. She's also got 2 milligrams of morphine available for pain as needed every 4 hours.
Okay.
Question 26. You hear a GP talking to a patient who has acne. Now read the question.
So how can I help you today?
Well, basically, I've got a bit of acne, Doctor. I mean, I had it as a teenager, and I was given some cream which seemed to do the trick, but I can't remember what it was called. Do you think I could get some more of it?
Well, it may not be the same type of acne you had before, because there are 3 types actually. We call them mild, moderate and severe. And from what I can see, you seem to have mild acne. So this might just be caused by a build-up of grease on the skin. How long ago are we talking about?
It must be about 10 years back. I was still at school. I wasn't living around here then.
I see. Well, the recommended medication may have changed since then, of course. Did you have a prescription, or was it over the counter?
I couldn't tell you.
Okay, not to worry. Tell me, how long has this particular episode been going on?
About 3 months now, and it just doesn't seem to be getting any better. I've been using special soap and stuff, trying to keep my skin clean. Do you think I should see someone at the hospital? I saw online that they've got a dedicated dermatology unit.
Well, I think there are a number of things we can try before we need to think about that. So let's start by discussing which soap.
Question 27. You hear a surgeon briefing his team before an operation. Now read the question.
Our first patient of the day is a repeat laparotomy. He's got an unexpected finding after surgery for an appendix abscess. He's got a tumour at the base of the cecum. So he's going to need a bit more of a detailed laparotomy and resection. I suspect we're going to have to convert to open surgery sooner rather than later. I wouldn't open a lot of laparostic instruments at this stage, though. We'll just see how it looks. It's a couple of months since he had his original surgery.
So just an entry port and one other?
Yes, that's right. We don't expect any anaesthesia problems at the beginning because he's fairly fit and well, except for his epilepsy, which is under very good control. His BMI is also 35, but it shouldn't affect us. We don't need the obesity bed for him.
Question 28. You hear a nurse educator telling a group of trainees about pressure ulcers. Now read the question.
As we saw last week, adult hospitalized patients are given the Norton scale to establish the risk of pressure ulcers. If, when applying the scale, the score is 5 to 10 points, that is, elevated risk, a blue sticker should be placed on the bedhead in order to inform and alert the patient, family members, and the interdisciplinary team of this risk. Once the patient is placed at blue level risk, the patient and the family must be informed of the care plan established to mitigate it, and a special clock will be placed at the bedside to prompt changes in position. In the case of pediatric patients, however, the scale isn't applied, but this is to do with the limitations of the scale rather than the absence of risk. Neonates and pediatric patients hospitalized in critical areas, as well as children with limited mobility due to neurological disorders, and of course those who rely on orthopedic devices such as splints, casts, etc., are all considered at high risk.
Question 29. You hear a GP talking to a patient. Now read the question.
So, how can I help you today?
Well, what's happened is my brother's just been told that he's got this condition where there's too much iron in his blood. I can't remember the name, but it was hemo something.
Hemochromatosis?
Yeah, that sounds right. I mean, he's having treatment and he's going to be okay, but apparently what the specialist told him is that this can be passed on in the genes. So if he's got it, then there's every likelihood I've got it too, that I should have a blood test, because if it's not treated, it can lead to other things, even if you've had no symptoms yet.
I see. And did your brother tell you anything else?
Yeah, he said it wasn't the full condition because of another thing. He read out a string of numbers and another long name.
Oh, yes, I know what that might be. Okay, well, let me explain a bit about this condition, and then we can decide what we need to do.
Question 30. You hear two nurses conducting a handover at the change of shift. Now read the question.
Next, we have Mrs. Floyd, who's sleeping at the moment.
Okay.
She's a 60-year-old who was admitted as an emergency overnight with a suspected bowel obstruction. She has a history of bowel cancer, resected 5 years ago.
Okay.
The doctors are looking into whether there might be adhesions or a stricture at the operation site. Obviously, she's concerned that the cancer may have returned, and her daughter's coming in later to speak to the doctor. That's all set up.
I see.
Meanwhile, her temperature is 37.8, pulse is 80 beats per minute, and respiration 25 breaths a minute.
Mm-hmm.
Blood pressure is 150/90. She has a nasogastric tube on low-pressure suction to manage nausea and vomiting, and intravenous normal saline at 125 millilitres an hour.
Okay.
The next bag needs to have potassium chloride added. See the orders for that.
Okay.
Her skin's quite dry but intact, and you'll need to consider mouth care.
Listening Part C. You hear an interview with a dietitian called Ellie Parr on the topic of belly fat. You now have 90 seconds to read questions 1 to 6.
جيبها رايحة تغسل جيبها
My guest today is Ellie Parr, a dietitian and associate professor in nutrition at Deakin University. Ellie has been speaking recently about the dangers of belly fat. So Ellie, tell me, why are you raising awareness about this issue?
Well, Australians are getting fatter, and there's no dispute over that fact, and the fact that this increasing weight is affecting our health. Excess storage of fat is linked to many different chronic diseases, but some areas of fat storage on the body are worse than others. In general, women have greater absolute body fat percentages than men. Typically, women carry more fat around the legs, hips and buttocks, as well as the chest and upper arms. Women have more subcutaneous fat, the fat that you can pinch under your skin, while men typically have more visceral fat, which is stored in and around the abdominal organs. People who have greater fat stores around their buttocks and thigh regions are at lower risk of chronic disease than those who have greater fat stores around their middle.
Why is belly fat more dangerous?
Well, researchers have found excess visceral fat storage is a significant risk factor for metabolic health complications of obesity such as type 2 diabetes, fatty liver and heart disease. Fat cells in a healthy person are able to grow, recruit inflammatory cells to help reduce inflammation, and remodel themselves in order to allow for healthy body growth. But if there is excess fat tissue, these mechanisms don't function as well. And with excess fat, the body can become resistant to the hormone insulin, which maintains our blood sugar levels. Visceral or belly fat secretes greater levels of chemicals that trigger inflammation and releases more fatty acids into the bloodstream. Whereas the fat cells in the leg region and the pinchable subcutaneous layers of fat around the middle store fatty acids within themselves rather than pushing them into the circulation.
Do you think most people should just try and lose fat from anywhere?
So a recent weight loss study that looked at where fat mass was lost found that areas of fat loss didn't change the risk factors for heart disease and stroke. The important thing was losing fat. While diet and exercise are unable to specifically target regions of fat deposits, fat mass loss from anywhere can improve the risk factors. Online advertisements might tell you that a magic workout machine will reduce fat in one particular area, but we can't target fatty tissue the same way that we can target a specific muscle group. Total loss of fat through healthy diet and exercise is the best outcome for overall health and reducing either the symptoms of chronic disease or the risk of developing diseases such as diabetes or heart disease.
I see. And what do you mean when you say a healthy diet?
Well, if we look at just two key elements, carbohydrates and fructose, carbohydrates provide a quick energy supply that's easy for the body to use, but the body and brain don't need carbohydrates. Your body does need glucose, which can be obtained from carbohydrates, but glucose can also be obtained when it's converted from protein and fat. This means the lower your carbohydrate intake, the more the body uses fat for energy. Fructose, which is found in fruit, is something you should definitely avoid if you want to help your body get rid of fat. It's true that fruit can be good for your health as it contains fibre and vitamins, but to lose fat from around your body, it is important to limit the intake of fruit. Fructose activates an enzyme which activates other enzymes, causing the body to accumulate fat.
What about those who do eat well but still can't lose fat from around their belly or anywhere else?
Well, if you sleep for less than 6 hours a night, that can certainly be a contributing factor. There was a study done over a 16-year period that took into account almost 70,000 women, and that study found that those who slept 5 hours or less a night were 30% more likely to gain 13 or more kilograms than those who slept 7 hours. Stress is another issue. The stress hormone cortisol has been known to increase the amount of fat a person's body maintains and to also enlarge your fat cells. Higher levels of cortisol have been linked more specifically to increased visceral fat. Age is also an issue. As you get older, your body changes how it loses and gains weight. Both men and women experience a declining metabolic rate. In addition to that, women have to deal with menopause, and if a woman gains weight after menopause, it's usually more likely to be in their bellies.
And what should people do if they're worried about the amount of fat they have around their belly?
Well, remember that not all fat is the same, and some overweight and obese people with a store of excess fat around the middle of the body might also have more muscle mass, which could be protective. However, by the same token, if you have fat around the belly and it's greater than the size of your hips, you should see your doctor to assess your cardiovascular health and fat distribution.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a presentation in which a researcher called Dr. Sarah Jones is talking on the subject of weight loss interventions by GPs. You now have 90 seconds to read questions 37 to 42.
My name's Dr. Sarah Jones. Today I'm going to be talking about brief interventions for weight loss. What that basically means is helping patients to get started on the road to losing weight, and I'll be introducing you to some exciting new work on the subject. I've been interested in obesity for a long time, and it's an issue that matters. 2/3 of adults in this country are overweight or obese. So I absolutely recognise that we need interventions which can be part of routine care. The reality is, however, that relatively few practitioners actually make such interventions, despite the fact that this is an established part of clinical guidelines in many parts of the world. Now, why is that? One reason, I think, is that they tend to have an attitude that goes, "What can I really achieve in a brief intervention?" Now, that's a reasonable concern. But when we did a review of weight management services led by health professionals, there were so few of them that it was difficult to know whether or not they made much difference. As a result, we decided to do our own trial, which we called Brief Interventions for Weight Loss. What we did was train GPs to make a very brief 30-second intervention with every patient coming into their routine clinics who had a BMI greater than 30. Basically a brief chat saying, "While you're here, have you thought about the benefits of losing some weight?" The reason for doing this was to get patients who weren't really thinking about their weight to focus on it for a moment. If the doctor raises the issue in this way, we can capitalise on that heightened awareness by offering them support. By referring them to a program, we can create lasting motivation to lose weight. So, that was the theory. How did it work out? What I'm going to say next should provide huge reassurance to practitioners. Our first step was to conduct a survey of 500 likely candidates for the trial. Although weight remains a very delicate personal issue in the public domain, only a tiny proportion of those surveyed thought it was inappropriate for their doctor to discuss weight loss on a professional basis. Given the need for urgent action on the issue, I think that's a pretty strong mandate. Anyway, as I said, this was a trial, so there were two groups of patients. With patients in the first group, the doctor formally raised the issue of weight and offered a referral to a weight management program. For patients in the other group, which was the control group, the doctor simply said, "It would be good for your health if you lost some weight." So what happened when this weight loss intervention was trialled? Well, the answer is that 3/4 of those offered referrals said, "Yes, doctor, I'd like to do that." That was an excellent start, but we're realists. And of course, they didn't actually all turn up. But nonetheless, a large number did. Of those who accepted the referral, more than half attended the program. Now, that's a fantastic result, exceeding our expectations, and indeed most of them completed it. So given that it was a completely unselected, totally opportunistic intervention, we were quite encouraged at the uptake for this program. But of course the crunch is, what happened to their weight? Well, at 3 months, people in both groups had lost weight. The control group, you remember they'd simply been advised to lose weight, but were left to their own devices in terms of what they did about it. Now, they'd lost 1.75 kilos on average. Meanwhile, the group attending a weight management program had lost significantly more, about 3 kilos. When we followed both groups up again at 12 months, patients in both remained below their baseline weight. But the intervention group had again done significantly better than those people left to manage their weight independently. This is an interesting trial because it allows us to model what the effect would be if GPs made this kind of brief intervention more widely, just once a year for each eligible patient. So, how scalable are the results? By 2035, run countrywide, such an approach could reduce the prevalence of obesity by half. That's a dramatic result, showing that these brief interventions not only help individuals, but could also lead to huge gains for everyone in terms of better health and reduced healthcare costs alone. So, to sum up, I guess what I want to convey to you is that brief, opportunistic interventions from a doctor to encourage weight loss, when made in a supportive manner, are really to be encouraged. Thank you.
That is the end of Part C. You now have 2 minutes to check your answers.